keeping you awake. So we'll ensure that the questions asked throughout this panel are entertaining and energizing, just in the same fashion and format as the previous two panels. This final panel is focused on healthcare affordability, and we have four very distinguished panelists who I'll now introduce. Arjman Siddiqui is professor in the Division of Epidemiology, Dalalana School of Public Health at the University of Toronto, senior scientist and Edwin S. H. Leong Chair of Child Policy Research at the Hospital for Sick Children in Toronto. At the University of Toronto, she held the position of past Canada Research Chair in Population Health Equity and holds appointments in sociology, public policy, and women and gender studies. She is also a very proud senior fellow of Massey College. She holds adjunct professorships at Harvard University and the University of North Carolina, Chapel Hill. Dr. Siddiqui's research focuses on understanding the nature and causes of health inequities, with a particular emphasis on how they are influenced by social policies and other societal conditions. Dr. Siddiqui frequently works with organizations, including government and international agencies, on issues of social determinants of health, health inequalities, and related matters. She was a member of the World Health Organization Commission on Social Determinants of Health. She is the recipient of the 2022 CIHR and Institute for Population and Public Health Mid-Career Trailblazer Award. She received her doctorate in social epidemiology from the Harvard T.H. Chan School of Public Health. Dr. Chris Simpson is Executive Vice President, Acute and Hospital-Based Care, and Chief Medical Officer at Ontario Health, the provincial Crown agency that oversees and operates Ontario's healthcare system. He's also a professor of medicine and a cardiologist specializing in heart rhythm disorders at Queen's University and Kingston Health Science Centre. He was chief of cardiology at Queen's for 10 years before being appointed vice dean at Queen's Health Sciences. During his tenure, he stepped in as acting dean and acting CEO of the Southeastern Ontario Academic Medical Organization for 6 months. He has served as an American College of Cardiology governor and on the boards of Canadian Cardiovascular Society, Cardiac Care Network, Core Health, and the Council of Canadian Academics. He chaired the Canadian Wait Time Alliance for 5 years, ending in 2016. The Wait Time Alliance developed evidence-based wait time benchmarks for over 1,000 surgeries, procedures, and specialty consultations. He was the 2014-2015 president of the Canadian Medical Association, championing seniors' care and helping to guide the profession through changes in medical assistance in dying and cannabis legislation. He went on to serve as Canada's representative to the World Medical Association from 2017 to 2019. He served as president of the Canadian Academy of Health Sciences from 2020 to 2021, during which time the Academy developed scientific assessments on autism and dental care, which have served as the foundations for a national strategy on autism and the recently announced National Dental Plan. Dr. Simpson's clinical, academic, and policy interests include inherited heart rhythm disorders, cardiac resynchronization therapy, leadless pacing, access to care and wait times, healthcare workforce planning, and seniors care. Myrna Adams is a dedicated leader and volunteer based in Brampton and the surrounding areas with over 40 years of service to the community. Her commitment to supporting those in need led her to collaborate with over 50 nonprofit organizations and presently serves on approximately 14 boards and committees ranging from all different levels of government. In recognition for her extensive volunteer work, Myrna was honored as Ontario's Senior of the Year in 2017, and the following year she was recognized in the House of Commons during Women's History Month for her significant impact on shaping Canadian society. Most recently, Myrna was awarded with the Lifetime Achievement Award from Prime Minister Mark Carney for exemplary service for community engagement and volunteerism to this country. Demonstrating her commitment to cultural preservation and education, Myrna is also the founder and chair of the forthcoming Brampton Museum of African History and Culture. This initiative aims to celebrate and educate the public about the rich African heritage and the many contributions to society. Myrna's unwavering dedication to volunteerism and community service has made a lasting impact on the community, reflecting her passion for fostering a supportive and inclusive environment for all residents. Now I'll introduce our moderator for this distinguished panel. Renee Serbu is a PhD student at IHPST. Renee received her Bachelor of Science in Human Biology, Bioethics, and Philosophy at U of T, and her MPH in Health Policy and Public Health Modeling from Yale, before spending 2 years as a pre-doctoral researcher at Yale's Digital Ethics Center. Her research explores the intersection of mortality and digital technology, focusing on human-computer interaction, brain-computer interfaces, and AI in clinical settings. Please join me in welcoming this panel.
Great. Thank you, everyone, for being here. Thanks to the audience and also our esteemed panelists for joining me on the stage for this discussion today. I think we'll start with a little warm-up, so maybe just one open question for each of our panelists. I've been specifically requested not to start with Myrna, so I guess we'll start with Chris. I'd like to ask each of you, though, in turn, so Myrna, get ready, please. I guess there's many dimensions along which the discussion of affordability and healthcare in Canada collide, not least of which include access and infrastructure, for example. For you, what is the most important thing that you see as one of these dimensions that people are still not discussing, that they're not seeing clearly? Or rather, where do you see that intersection most sharply from your own vantage points? So Chris, if you could lead us off.
Yeah, I guess the way I've always kind of seen healthcare is the way a physician colleague of mine from Saskatchewan talks about it, Ryan Miley. We talk about our health in a way that that is part of our everyday lives. How are you doing? Well, at least I have my health. You just had a baby. Is it a boy or a girl? Well, it doesn't matter as long as the baby's healthy, right? It's something that's kind of fundamentally important to everybody. And the missing piece, I think, has been that we've never sort of regarded health as the common public good that it should be. And Ryan talks about us talking about the GDP as being sort of the measure of how well society is doing. But wouldn't it be wonderful if we could talk about health in the same way, and have metrics that say we're going to measure the health of our society in this way, and we're going to have a health in all policy approach so that we can bring in not just the healthcare system, such as it is, but also all of the other aspects of our lives and government's impact on our lives that influence those outcomes. So that's a bit of a utopian view, but I think it's kind of a nice North Star to have.
Thank you. Raymond.
Yeah, I can't disagree with anything that my co-panelist just said, and maybe I'll just take off from there. It's interesting if we look at low and middle income countries, they often do use health as a metric of progress. So you have many kind of United Nations and so on development indices that incorporate that. And I think we sort of underestimate how powerful that would be in our own society. I think there's a couple of ways that I see an intersection. One is the extent to which the system as it is sustainable and affordable for our society, the extent to which individuals can afford care within that system at points where they do have to pay. And then the third, maybe, which overlaps with much of this, is the notion that that so much of this is systematically stratified by social and economic position. And what we've seen over the last several decades now is that that stratification, that social stratification of health is growing, it's intensifying. And so the gaps between the richest and the poorest, for example, in their level of health is worsening. And so when we think about our system being burdened by healthcare needs, that is very tied to the circumstances of often the least well-off among us and the kinds of lives that we are sort of subjecting them to, and the worsening of that over time.
Thank you. Myrna, you knew it was coming.
I should have. Okay, I do agree certainly with what my esteemed panelists have said. From my vantage point, and I have notes here, so I'm going to read from that. The sharpest intersection is not just the hospital wait times or access to doctors. It's the everyday realities of people trying to live well. It's the senior who has to choose between paying for medication or buying groceries. It's the caregiver stretched thin because supports are unaffordable or unavailable. It's that reality that housing, food, transportation, and social connection all directly shape health outcomes. We often talk about healthcare as a system, but people experience it as a condition of their lives. And when affordability is out of reach, health deteriorates, long before someone enters a clinical setting. Another piece that we're not seeing clearly enough is that the system is still largely reactive. We invest heavily once people are already in crisis, but we do less in upstream supports and actually keep people well. Things like community-based care, preventative services, and culturally responsive supports.
Thank you. Each of you touched a little bit on themes of sustainability of the system in general, the burden and where it's most greatly felt, as well as this intersection that we are kind of theming this symposium today on with respect to housing, income, and social policy more broadly, and how those things kind of intersect to affect healthcare outcomes. So Arjun, I'd like to kind of follow up on what you were talking about and bring up a discussion of social determinants of health. So some would say that the first priority in fixing healthcare delivery before widening the frame to social determinants is just that. Let's focus on delivery at the first point of care. So where do you agree, and where would you say that logic falls short?
Yeah, I'm not totally convinced that trade-off is the way that things have to be, that we have to focus on delivery at the expense of social determinants. What we find internationally, for example, is that you find social policies and healthcare policies often cluster, so that you see societies that have more, equal access to healthcare are often the ones who also have better social conditions for their citizens. So I'm not totally convinced that it is a trade-off. I think there can be an argument made that resources are finite, and in that context, people are struggling to figure out, what to prioritize in policy terms. Again, I'm not totally convinced that we're always correct in that assumption, at least as the way we frame it. But if it is true that there is that trade-off, I think Myrna's point is very well taken, which is that we tend not to think that we have to actually invest at the front end. And the front end is probably what will give us the most bang for our buck.
To open that up, if anyone else cares to add a response.
Well, I would certainly agree with that. I think, the traditional healthcare system, if you go back to the 1960s when we sort of imagined this in Canada, it was sort of about hospitals and about doctors. And to this day, the public investment is largely focused on hospitals and doctors. But the landscape has changed. You know, the environment then was one of acute disease. The environment now is much more complex. There's a lot of chronic disease, and there are a lot of factors upstream, as we say, that deliver the results that we see. And so the approach that I think the system is trying to take is to try to move more upstream. And one of the things that's most proximate to the acute care system is housing. And so there's a lot of talk now about bringing housing into the formal discussion sphere of the healthcare system, and that's not novel or revolutionary to anybody sitting at the panel. But for the healthcare system and people who work in it, that is a revolutionary idea to start to talk about housing, as something that healthcare providers should be interested in, and it's perfectly obvious why we should be interested in housing, because it helps to deliver better health. And if we're in the business of delivering better health, we need to prescribe not just medications and surgeries and treatments, but Gary Block talks about prescribing income and prescribing housing. And these are interesting concepts that if we can start speaking the same language, then we can start to have some really interesting integrative discussions.
So with respect to this housing question, actually, I think what would be interesting would be to frame it perhaps as a gap between what public experts maybe expect from the health system and what the system can or cannot currently deliver. Do you see this as a gap that can be filled, or something that we are actively working towards filling?
Back to me?
Back to you. Follow-up question.
No, I think so. Certainly, my view is that the efforts to fortify the primary care system is a good start, because this concept of the primary care home, when you listen to Jane Philpott talking about it, you have a community or a neighborhood of people, and when you live in that community, this is where your kid goes to school, and this is where you get your health and social care kind of thing. And it's kind of got this kind of wraparound feel that it's a system that kind of understands the diversity of people who live in the community, the uniqueness of what they need as both a community and as individuals, and it's able to bring to bear the resources that are available to achieve health, not just in traditional delivery of healthcare, but in other social services that can be provided. And I think when it's framed in the collective that way, it becomes easier to conceptualize how to make the best investments. And it allows us to collect data as well, because we tend in our society to overvalue the things that we measure or that we can measure, and we tend to undervalue things that aren't being measured or can't be measured as well, even though they might represent very fragile and important outcomes. So the more we can sort of focus, I think, on adopting equity data, not just at the collective level, like it's done now, but at the individual level. When we have individual level socio-economic and socio-demographic data, then we can be really precise, not only on where people need to be lifted up, but we can measure accurately the impacts of our interventions that we design.
Thank you. And kind of to take the concept of data in its also narrative form, I'll turn to the question of communities. And as a result, I'll ask you, Myrna, what burden would you say is being pushed onto families and community organizers, given that the formal system is so hard to navigate or often slow to respond?
Families actually become the unpaid caregivers and coordinators. And when this happens, there's a lot of financial cost associated with that within the families. The stress is actually strengthened within that family. When I say strengthened, I don't mean a positive manner. Younger people are looking after their children. you are now having to look after an elderly person within that home. It is a very stressful, extremely stressful situation, which actually can and often does lead to elder abuse. And we know that. We have people that we're constantly getting calls from on a daily basis asking us to be able to take them out of that situation, to bring them to safety, which it is a very difficult thing. And oftentimes hospital systems or healthcare systems, they actually prioritize systems efficiency rather than actually looking at what can be done for people to make things better for them. Because it is a difficult thing, and we don't always have families that are around us to be able to support us. So we have to look at other institutions, which then also stresses that places the burden upon them and perhaps our neighbors. So I don't know, sometimes we have to travel in order to be able to look after an elderly person. And that's not good either, because that's also very stressful. And I don't think sometimes we can give our best care when we are under stress. We need far more supports. We need people that actually listen to seniors, because often seniors' voices are not heard. And when we ask to have, we've lobbied the government to get us to have a dedicated seniors advocate, so that that person or people can actually go to seniors, listen to their needs, not to come out and tell seniors what they need or what they should want. It's what they actually need. To go back and to report to the legislature once or twice a year, so that there are some changes that can be made that would benefit seniors as a whole.
Thank you. Yeah, that's a really interesting kind of dimension of this conversation, as well as the family need and the family burden, as well as the recipient of care and their burden and their independence. And so I would like to ask you maybe to follow up a little bit more on that. What is something in your experience through lobbying and through having these dedicated discussions that you feel that policymakers or the government have consistently misunderstood about what seniors do need in order to be well and to be independent?
Well, I do believe that the system believes that seniors' health, these are episodic things, but it's not. It's the seniors' daily living. They have to live with this every day. And I don't believe that they actually understand that, or that they listen to actually hear that. So the changes are not being made. Seniors are, at a certain time in a senior's life, systems actually look at them as if now they are indispensable, that we really don't need them, that they're that the value is actually not there. So we don't want to hear from the senior. We want them to be out of sight, because the young people are coming along. They're more valuable than what that senior is. So that's something that has to change. That's why many seniors now are more engaged, so that they can be at the table where decisions are being made, so that they can actually make decisions about their own well-being and their lives, and to tell politicians, people that are in decision-making stances, that they can listen and hear what is really necessary out there.
This empowerment, I think, is certainly at the table for discussion. It needs to be at the forefront of the discussion. I know in my life, I have quite elderly grandparents who are immigrants. We're all Romanian, and they don't speak English at all. And so navigating that system in a different country and with a language that is not their own has been a challenge. It's certainly a challenge, to the family support system. But above all, I think part of that challenge is this lack of empowerment that they feel to step up to the conversation. Surely at this age, they have kind of, retreated from this discussion, and they said, it's whatever's going to happen is going to happen. But 10 years ago, that wasn't the case. They were really vocal and involved, and I think it became kind of a question of health equity and disenfranchisement to lose that voice and to lose that independence. And it's hard to see, and it's hard to not continue to press upon. And so on that note of health equity, Arjun, I'd like to kind of return to what you were saying about burden and where the burden is felt in a population during a healthcare affordability crisis. So from this lens, who is absorbing this high cost right now? Of course, it's not going to be one demographic group, but what sort of elements of this question are policymakers underestimating? I think one of them could be just assigning a singular demographic group. But from your experience, what do you think are the greatest risks that we're seeing crop up in this space?
Yeah, it's a great question. If you think about a society like, let's say, Ontario, if you take any given individual in that society, one of us, one of the audience members, it could be really anything that's determining their health, and it's usually a combination of various things from their social lives to their genetic predispositions to anything in between. But if you zoom out to the population level and you think what's making Ontarians healthy or not, who's getting sicker than others, it's very systematically patterned, and it's patterned by your social and economic conditions first and foremost, and that's really what drives everything else. It's what drives stress levels, it's what drives healthcare access, it's what drives material resources for food and housing and other conditions. And so very often, irrespective of the health outcome we're talking about, whether it's chronic conditions or COVID, the people who are the most at risk for poor outcomes and for being sick and then not receiving adequate care are people who are the most socially disadvantaged. And I think there is some concern that Myrna's point about the elderly also spills over onto people who have fewer means, and that we tend to be less respectful, less sort of attentive to the fact that the patterns are what they are, and they are not because more disadvantaged people aren't taking care of themselves and so on. It's because of the conditions of their everyday lives. I think Myrna alluded to that. So to Chris's point about housing and other conditions, you really see time after time the value of paying attention to socioeconomic conditions, because those tend to be the groups that experience the worst outcomes. I will say one other thing to your very good point, Renee, about not sort of identifying just one demographic. The other interesting thing about health at the population level is that it's not generally an either or. Poor people are unhealthy and rich people are healthy. It's really a continuum. So if you look at the statistics, it kind of shows that our health is kind of a function, an incremental function of our resources. So you see kind of a gradient from poor to rich, if you will, rather than some binary that says poor people are unhealthy and the rest of us are saved. You really see that we're all kind of in this, in the sense that we're only incrementally different from other social groups around us.
Yeah, if I may, I just wanted to pick up on some of Myrna's points about seniors. And when I was president of the Canadian Medical Association, my platform was seniors care, and the pitch was we were lobbying the federal government to create a national senior strategy. And that included things that you might not necessarily think of, like making the caregiver tax credit fully refundable, for example. Just something little, but it puts some money in people's pocket, right? Just to show them some support. The thing that I think had some legs was we designed this thing called Demand a Plan, which was an advocacy effort. These were the days when I said, oh boy, if they'd only put me in charge. So we partnered with like the Canadian Association of Retired Persons and with the Legion and the Canadian Labour Congress and the Canadian Association of Retired Teachers, and these groups who had seniors who were kind of powerful advocates with a lot of skills, speaking up. And I think the thing when I fast forward to the job I'm in now, and I think about the number of people who are in acute care hospitals simply because they're waiting to be in a more dignified and appropriate place, whether that's long-term care or even better, home with appropriate supports. The conversation has changed from calling those folks this horrible term bed blockers, which was a really dehumanizing term. And now there's an explicit recognition that this is fundamentally a quality and dignity issue. And that elevates, I think, the conversation and gives purpose to the people working in this space by saying, you know what, we're not doing right by people by not providing them with the resources that they need. And what that's translated into in the last couple of years in Ontario is, for the first time in many years, and unlike every other province, we've reduced alternate level of care patients in hospitals because we've been able to put more effort into home resources. We have this hospital to home sort of program which accelerates people who are no longer acutely ill, but they in order to be independent, they just need a little bit more support at home. We've even got this hospital at home sort of concept now. And the whole thing is en route to what I call dehospitalizing the system for more people. I really think that there are enough hospital beds to look after people with heart attacks and strokes and cancer. We're always going to need those resources, but what we need to do is create more opportunities for people who don't need the acute care hospital, so that the acute care hospital isn't the place you go simply because there's nowhere else. That can't continue. And so but it all has to be grounded in doing it for the right reason. I feel much more comfortable framing the whole issue around how do we achieve dignity and respect and health. They go together for people, for all people who deserve it. And it's a much more compelling, I think, argument to make when you frame it in those terms. And I'm very encouraged that there does seem to be some incremental investments and some innovation in dehospitalizing the experience for older folks who, for the most part, just need some support at home rather than languishing in a hospital bed. Who wants to live in a hospital?
Thank you. Yeah, that has me thinking about kind of this element of the system improving versus merely working harder, right? So I'm wondering these elements of satisfaction, right? Dignity and kind of empowerment and independence. They're all pretty qualitative aspects of life, and so there's not really any seeming performance measure that we can just assign to mark this as like an improved metric, right? The numbers are up, so we've done a good job at improving the system. So given this nuance, what is something we can look towards to confirm that the system is indeed improving and not just working harder? That's an open question, of course.
Well, I think data, it's easy to do more stuff. It's easy to do more volumes of things. But in my view, these are transactional terms, and I'd much rather sort of talk about outcomes for people, and particularly equity outcomes, and where we can close the gap where people have been left behind. And I think, you know, when I think of some of the stuff we've been doing at Ontario Health, like with our Ontario Structured Psychotherapy Program, we're collecting, you know, individual socio-demographic data so that we can really understand where the gaps are, like who is getting access to this care, 50% of whom get sustainable improvement, and who's not. Where are they getting it? Are there certain kinds of folks? Is there a gradient, as Arjun described? With our not our breast screening, but our lung screening program, the same thing. In almost everything else we do, we try to apply forward sorting area or postal code data. So at least, you know, it's not an individual level sort of metric, but at least we understand that areas that have, you know, a higher proportion of Black folks, let's say, they have these kinds of outcomes, and so that's a signal. You know, there's a gap here. We need to do something about that. So this equity sort of lens is baked into the legislation that created Ontario Health, but there's nothing like data to create a burning platform for change, and that's really, I think, if there were one thing to kind of speed up, it would be the acceleration of good data that shows us where the equity gaps are.
Yeah, I fully agree. And actually, I should give kudos to Ontario Health. I had the pleasure of working with their population health and social determinants of health teams who are trying to use the forward sortation data and other data to understand health equity. And I, you know, sort of consulted with several of their teams, and they're so committed and really trying to work hard on this. What I would say in terms of the point of some of the softer, quote unquote, softer measures, I wonder if, to Chris's point, data, what we need is data to tell us about different things. So one might be system functioning. One might be sort of, are people getting the care that they should be getting given their clinical and social circumstances? One might be, how are patients feeling about the care they're getting? And when we kind of look across data like that, we can get a better sense of whether the issues are system performance. If they are system performance, is it about things like efficiencies? Or are we neglecting certain groups in certain geographic spaces? Or are we not somehow being able to register that the care is actually translating into people feeling better in many different ways. So in fact, I'm not sure. I think sort of harder clinical outcomes, but also outcomes that have to do with the quality of people's experiences and the quality of their lives can tell us something. And it is true that often, as I said, you know, and as Myrna kind of alluded to, Chris as well, everything doesn't boil down to the healthcare system, that people's everyday lives are causing them to be sick or to stay healthy. And so if we get that data, it's not to say that the healthcare system is accountable for all of it, but it may be that the healthcare system is a very good place to collect this data, to learn about what's happening to our population, and to not be fearful that this is about asking one system to take everything on, or to ask hospitals to take everything on. But it is a way to learn about the health of our communities.
Just to add something to that, data collection is always wonderful when you actually involve the people that you're collecting that data from. And oftentimes, researchers do not do that.
Indeed.
They go into a community, or they will ask a certain segment within the hospitals now questions. They expect answers. They never go back and speak to these people at a certain time to say what is really happening with this data, what we found from it, what we have found from those questions, and how this is going to impact your life. That's forgotten. that is forgotten. And that's something that really has to be learned. If you're on a stretcher going into the hospital, right? You're in pain, and somebody wants to stand there and question you and ask you what your sexual orientation is at that time. Would you be very happy about answering that question?
Probably
I don't
not.
think so. No. And I do sit on some of the Central West Ontario health teams, so I know some of the things that they are wanting to ask people. Another thing is that when people are treated differently, you cannot build a relationship and you do not build trust with your health providers. And we see that not only years ago, but we see it today. If you have a different accent, if you dress a certain way, if you're not educated, you're treated very differently. So the outcomes are not good. We cannot, like oftentimes, because I can speak, I am Black, that Black people are often considered as being non-compliant when they go to the doctor, right? You've prescribed 15 different medications. They can't afford to pay for those medications. So they either don't take them as they should, and then when you go back to the doctor, now the doctor says, oh, here we go again. Here she comes, non-compliant. What am I doing with her? And that happens very frequently. And things are still happening. We know that. And I'm from the Peel region. We've just got a Black health social services, a Black hub and a Black health and social services hub, so that people can go and relate to people that reflect themselves, that understand them. And we need more than one of those things. Black women are still dying in the hospitals during childbirth. Their babies are dying at childbirth or within the first year. So there have to be some changes. You can't keep overlooking a segment of your population. The world has changed. Every time you look out the window now, you don't always see a reflection of yourself. You see somebody else standing there looking back at you, and you must take all of that into consideration and make the appropriate changes.
Absolutely, Myrna. Thank you so much for that lived perspective as well. I think we often look, I've turned to health tech and AI policy in healthcare, and one big question for us is certainly data security and data privacy. And what surrounds that discussion is one of trust, right? Trust in the medical system, certainly in the clinical context and with the provider, but also just longitudinal trust building and relationship building, right? We have improved measures of point-wise data collection, and we're doing a great job at kind of securing these instantaneous, or I should say maybe like a snapshot data, bulk data collection kind of outcomes. But I think one area to improve on is this retention, right? And that retention is built through trust within communities, especially within those communities whom we are choosing to represent and wanting to speak on behalf of. And there's definitely no way in kind of improving those metrics of trust without asking those community members what it is that they need in order to feel safe to provide that data in the first place. And so that is a discussion I think that needs to continue to be had, and certainly that we're not going to have the time to resolve in our final 30 minutes of this panel. But I wish we did, though. I will maybe open. I'm going to combine two discussion questions into one, and hopefully that's not too much of a cheat. But and to kind of open up the discussion one more time for each of our panelists before we turn to audience Q&A. But I'd like to ask each of you, in terms of priority setting for the next maybe 2 years or so, what if governments were to do one thing first, where should they start? Should they start at primary care, or access to primary care, community-based support, direct affordability relief, or something else? And where do you think that people in community would be feeling, the real difference? So basically, how do we resolve this in 2 years is my question.
Well, I don't think there's a wrong answer to that question, actually. But the approach in Ontario, which I think has some broad support, is sort of what I think is a generational attempt to really ramp up primary care. And the intent is to have most Ontarians attached to primary care, and as many of those as possible to a team-based model, because we know outcomes are better in a team-based model by 2029. 25. I don't have a time machine. So far the effort is on track, and considerable funding has been attached to that. But I think for me, if we imagine an immediate future in 2 or 3 years where we've got 2 million more Ontarians attached to primary care, and many of them to teams, that opens up all kinds of possibilities where we can go from there. To create a medical home or a place for people to have a front door to health and hopefully social care is sort of the foundation that we need to create, to build on. In fact, I'm not sure how you do it without having a strong primary care foundation. I would maybe flip it around and put it that way. So we have a unique opportunity, if we can pull this off and have most people attached to this primary care team-based environment, then I think we can start to really figure out how we're going to use this infrastructure to advance some of the goals we've all been talking about today.
I think I'm the least qualified on this panel to answer this question, but I think Chris's point about primary care is compelling for an additional reason, which you had alluded to before, which is that it can serve as sort of a community home or hub as well. And in my mind, the priority would be establishing some way for people to be able to consistently connect to the services they need. And so for me, it's more about creating some sort of infrastructure or system that allows that to happen, and then scaffolding everything onto that, so that people are never sort of scrambling for where to go or how to get there. And I sort of wonder if, I just keep, during this panel, I just kept thinking about Service Ontario and Service Canada, and wondering, to the idea, to the point of systems being kind of isolated from each other, and healthcare being connected to housing and so on. I think if you think about the Service Ontario model, it really was to bring together various services for a variety of reasons, from system efficiency to better kind of experiences with accessing services for citizens. And I wonder, again, if a community hub of that nature can take on that kind of orientation, where it serves many different purposes and allows citizens to kind of feel that they have a place to get dignified care.
I believe that the focus should be more on preventative care. We certainly do need primary care. I'm not suggesting that we don't, we do. But we should be educating people more from when they're young, as they grow up, how to maintain a healthy lifestyle throughout their lives. Let's take down some of these financial barriers that people encounter. There's services that are available, but if I can't afford them, what good are they? So we need more of that. We can't wait until everyone is in a crisis and then decide we're going to give this care. Let's help those people that are homeless and not try to hide them away or bring lawsuits against organizations that are trying to provide services for those people. Let's try to do something about that. Let's try to do something about our youth that are going to school, children that are going to school that are hungry. Let's do something about that. So it's not just availability, it's access. It's be able to come home and realize that you can set a healthy meal on the table for your children, that you do have a roof over your head, that you're not couch surfing, or you're going to find out where's the next open space that I can go into to sleep tonight. So let's do a lot more of that. And we're in schools, we have all kinds of schools. We got enough universities here and certainly many academics. So let's try to make a real positive impact in the community, because we don't live out of books. We live real life every day. Thank you.
Thank you. Certainly too many academics in this room, I will say. On that note, I'd like to invite everyone to thank our panelists with a round of applause. And we will open the floor up for audience Q&A, as well as if anyone is joining via the live stream. Yes, Carolyn.
You probably expected me to rise for this panel. For those of you who don't know, I focus on health policy. I'm interested, kudos, first of all, to the panel as a whole. Kudos to Ontario Health and the initiative of Ontario Health Teams. I think it's one of the most sensible initiatives to organize healthcare at the local, regional, district, or whatever we call it, level that we've seen in Ontario. That being said, we observe cross-nationally that these regional structures are very unstable over time. They keep getting reorganized and reorganized and reorganized, expanded, reduced in number. The issue that I want to ask you about is catchment areas. And I think one of the Achilles heels of regional models or district models, not just in Canada but elsewhere, have been that they are unique catchment areas. They don't align with the rest of the system. If you want to, with other systems, problems tend to generate their own catchment areas. And so trying to move to the community level, which research is increasingly showing is critical in improving social outcomes. It's at the community level that we need to make interventions. Amenities and supports at the community level have been shown to be more important than resources and supports at the household level to social mobility and the addressing of inequalities. So we need to be better equipped to find a unit of focus or a unit of delivery that is consistent enough across policy areas that we can actually gather data that link social problems, the experience of social problems, and provide some venue for intervention at the community level. So as supportive as I am of the concept of Ontario Health Teams, I wonder if, developing yet again another set of unique catchment areas we can't just stop there. We need to find some way that we can elevate or lower, wherever the optimal level of community is at which to focus. We need to find some way to align our catchment areas. Perhaps there is some such work going on, of which I'd be delighted to know there were. But could you say something, really all three panelists, about the potential for defining a level of community that is both appropriate for data generation and analysis and for the integration and delivery of services?
My colleagues are telling me I have to go first. Well, it's a really fascinating question. I think, the thing with Ontario is it's such a heterogeneous environment. You compare, a small isolated northern community to, the GTA. We have something like 12 of the OHTs now, I would say, are very high functioning. They don't quite have the sophisticated governance to sort of ensure that long-term continuity and protection from political cycles and everything. But they've got this really good coalition of the willing thing going. They've kind of defined their community geographically, and they kind of understand what they can deliver collectively, to make 1 + 1 = 3. The trouble is, I'm not sure the formula works, everywhere, and that's the challenge. Is sort of staying true to the concept of what we're trying to do, which is exactly as you described, this kind of regional delivery. But understand that it's got to look very, very different. We describe the what, but the how, must be very different. My experience with catchment areas has been that they've really served to be a barrier more than anything, because you get somebody saying, "Oh, that patient's not from my catchment area." Well, they need your care. They're coming. And so it works against this pull culture that we want to create, where patient needs to be here, everybody knows that. Why aren't they going? Well, not in my catchment area. Like that's kind of the barrier to this this borders kind of concept. So I think it is possible, through trustful relationships between organizations that agree on a common mission and a purpose. This is the suite of services we're going to deliver to this population. This is how we're going to measure it. We take guidance from the provincial programs that provide, the knowledge products and the support that they need. But you have that local delivery. Local delivery partners kind of take charge of exactly how it's going to be done. So I think I've just restated what you did, but that's I think that's the concept that it's trying to be built.
I don't know if I have much more to add, other than I wonder if it's algorithmic, so that you have some sort of geographic optimum. Maybe that is aligned with the data that's most easy to collect, which is postal code-based data. So it either funnels down to small postal code areas or is aggregatable up to larger regions or areas. But that we understand in good faith that those geographic boundaries aren't hardened. And so that if you do have people who are coming and need care, that there's an ethos that says, some of these boundaries are porous, and some hubs will serve as a location to give a certain kind of care, even beyond their team coverage, their routine team coverage, so that there is some sort of sense of being able to penetrate those areas. So maybe in some ways the issue is a combination of geography, but also other factors that may make it make sense to have team-based care and sort of certain hubs for certain kinds of service delivery.
I don't know that I can add much more. I do believe that the team approach certainly is a good one, but the community also has to be definitely involved there. It can't be just in the catchment areas. I mean, Toronto is a much richer place than the Peel region is. We're underfunded by $868 million yearly. So there's a lot that's not being done for the residents in the Peel region. So how do you overcome that? That's something that really has to be looked at. I think that if we had the hospital being part of the community rather than being this great institution, yes, that, it's elevated beyond all the rest of us. If they were part of the community, we would develop much better care for everybody, and they would learn more rather than ticking off boxes because the provincial government has set up a plan for what the hospital system has to do. So that's my take there.
We'll go Brohoth, and then I'll keep going.
Good afternoon. Thank you so much for the wonderful answers and the discussions that you're providing here. I'm Brohat, I'm a junior fellow here. I understand that part of the burden on the system is that we don't have enough human resources in Canada, staff, nurses, and doctors. That's placing a lot of burden. On the flip side, because Myrna kept on bringing up the idea of affordability, it is my interpretation that at least for Ontario, that everyone is on the Ontario Health Insurance Plan if you're a citizen of this country. Could part of the solution be to improve that plan? Because based on the answers that all of you have given, I feel like it's not equally accessible to people, specifically for senior residents, because if you're talking about affordability, my interpretation was most of it is paid by the insurance plan. So maybe it's not. So can part of the solution be, my question is, can part of the solution be improving that plan so that everyone gets that level of affordability that would help increase the access to these, I guess, health issues that can come up throughout their life?
Well, I can comment on the health human resources piece. I think everybody appreciates that COVID threw everything up in the air, and the legacy of COVID was, this reliance on agency nurses. So these would be like non-hospital employed nurses who were kind of brought in to fill holes and so on. We've made some pretty significant progress on health human resources in the last 2 or 3 years. The systemic vacancy rates are down considerably, back to pre-pandemic levels. Almost to what I would say is healthy levels for nurses. So the agency use is dropping off. That saves the system a lot of money, and it's better quality care. So that's a positive thing. Personal support workers is the other area that's, where we could really use a lot more of them. My stepdaughter's PSW. And there's some progress there as well. There's been really good partnership with the College of Nurses to find faster ways to licensure for people who've been trained in other countries and live in Canada so that they can function as nurses. There's something like 4,000 of those have been put into the system. So, incrementally and slowly but surely, the trends are all kind of positive that way. On the doctor side of things, I think there's a debate, do we have enough family doctors or do we not have enough family doctors, to fulfill this 2 million more attached to primary care in the next 2 or 3 years. And I think that's going to be one of these kind of incremental, just bully it into existence things too, because family docs do a lot of other things other than comprehensive primary care. And what we're trying to do is just get them, not necessarily to abandon, what they're doing now. Maybe they're working in a sports medicine clinic, or maybe they're a hospitalist or something. But, as these teams get established, if you could just devote, maybe 10 hours of your week to comprehensive primary care, join the team, be a comprehensive generalist. I think that's probably going to get us there. And then the unique problem in the North, I think, is you need a whole different phenotype of doctor to work in the North. You need somebody who's going to deliver babies and work emerge shifts and have their family practice and do house calls, and they're going to be leaders in the community, and you have to have a job for their spouse as well. And that's a totally different kind of phenotype of doctor. And there's a lot of innovation going on. Like my university, Queen's, is trying to build that kind of doctor at the Lakeridge campus. To sort of prepare them for that kind of community service kind of model. Like you're a servant of the community, you're not just a limited practitioner kind of thing. So all those things are kind of happening, and I see kind of gently positive trends in the health human resources space. We're not there yet, but it's improving. There was a second part to your question, but maybe I'll let the other panelists.
Yes, because we're not, yes, we do need to improve. Affordability is very important. Why do you, I mean, like everybody's not under OHIP. People on the streets are not always welcome. They don't have an OHIP card. That depends on the resources within the community to be able to look after those people. So things have to change. It can't be equal. There has to be equity because we don't all need the same things. We're not all at the same level in our lives. So there has to be more on equity. We have to look at what really is happening out there and how we actually can work together. Doctors, nurses, all the practitioners, health practitioners, we have to learn to work together because there's information that a community person can give to a doctor that the doctor does not realize what's happening in that particular community. So that would make things much better for all of us.
The mic is over here. I am just in the interest of keeping the queue. I'm going to pass my mic over here, and then we'll go right back.
Monty McMurchie. Fascinating, and I do not disagree with you. I'm going to use as my pericope, my entryway. There was a recent article, very intense, in the Globe and Mail about oral hygiene in the North. Why was there so much morbidity? Because they lacked water, potable water, so they relied on artificial sweeteners, and it destructed their teeth. Oral hygiene is one element to impart into the health program. It includes discipline, that you need to do your teeth, whether it's flossing or brushing, going through. But there's a fear element. And Tim Snyder, in his little book, Our Maladies, articulated that quite well, that he was an elite, went to the Yale medical system, and they botched it completely. And how he reflected in terms of what his own morbidity, what health is. Health is civics. Health is society. Health is social. Without health, you actually have very, very little. Give me wealth or give me health. The wise people would take health because wealth is very little without health. But there is no real solution because we're all, to use the Cantabrigian model, we're on a tripos. Health, housing, food. Take away one, the other two collapse. And how can you sate all three equally? It's going to require what I call courage, long-standing. The political leadership class needs to understand that I am elected not just to be re-elected. I am elected to do least harm. I'm elected to speak truth, ideally. And if I can work within the party, I will. If not, I need to call out the party. Health is our social fabric. There's no right or wrong in health. It's an attitude. As one person said, it's an ethos. Thank you.
Well, do we have any responses or? No, it's okay. We have one. Yep. So we'll go to this mic. I'm keeping the queue, but right.
Oh, I'm very lucky because you just going to talk about this tool of balance. So first, I want to thank you, Marna, for highlighting the Black Health and Social Services Hub, and thank you, Ontario Health, for giving us the money to open the Black Health Hub. That's it. Yeah. Give a shout out. They did a good job. So my name is Dr. Massey with Roots Community Services. So today I'm not a scholar, I'm a community member. And I just wanted to highlight that when we look at health, and yes, we do a lot of focus on primary health care and now focus on mental health, but when we leave social services behind, then that tripartite, that stool collapses because one leg is weak. So I think today we talked about planting seeds and seed sovereignty. So for seed in health, I just want to throw it back to look at, with the goal of 2029, making sure that everybody have a primary health care doctor, we also aim at bolstering the social services because as Mana highlighted, there's things that the community will know that they may not make it to the primary doctor unless it's through that route. We also know that from the Black community, Indigenous community, there's a lot of health mistruths based off anti-Black racism, based off all the structural racism that we have encountered. So sometimes for us to be able to reach the primary health care, we have to go through the social services so that we're able to reach there. So just putting out as we are building and bolstering the primary health care and mental health wellness, we need not to leave social services behind, because that's where all our social determinants of health are sitting. Thank you.
Maybe I'll just say one thing in response, which is I fully agree. I think there's two ways to think about not leaving social services behind. One is this sort of idea of social prescription and making sure that our health systems sort of facilitate people to be able to connect to available social services and vice versa. The other, though, is to think about the extent to which there are social services to access and their adequacy. You know, one of my grad students alerted me to this really kind of stark issue, which was that some of you may know that there was a pilot program that was canceled some while back to sort of start a basic income program in Ontario. So it kind of was squashed before it got off the ground. But my grad student alerted me to the fact that the basic income amount that had been proposed for the pilot was much more than people are currently getting for welfare, but it was less adjusted for inflation than people used to get for welfare during the mid-1990s. So some perspective there about where we are in terms of the extent to which our current set of social services are actually adequate. And I think that's the one kind of critique, if you will, or worry that people have, scholars in social determinants have around social prescribing, which is that it may underestimate the extent to which social services are actually inadequate, even if you are connected to them.
I think the queue has kept itself, so we'll stay with the mic, and then we'll go.
Yeah, and then I'm going to hand it back to.
And I think that might be it on time, just so we're all aware. Two more quick questions.
So I don't think this is a quick question, but I'll try my best. So I'm the Health Equity Research Lead at the Institute for Better Health at Trillium Health Partners in Mississauga. So we are, part of one of the largest hospital hubs in Ontario. And one thing that keeps coming up and has come up within this very esteemed panel is data, right? So we need the data to tell people that this is what's going on, and we need the data to tell people that we need to do this, and then we need to do that with the data, but we also need to tell people that the data makes sense. And I know I just kind of did a bit of a word vomit there, but what often is missing from that conversation around data is, yes, we do need socioeconomic status, data, all that stuff, but we also need consistency amongst the ways in which different organizations and institutions collect that data. So we're close to University Row right now, Hospital Row. If you go, Mount Sinai to St. Mike's and so on and so forth, the way that data is collected varies so much. And then the ways that data is interpreted varies so much. And then the ways in which that data is applied and the accountability parts of it varies so much. So I wonder for the panel is, we continuously hear that conversation around data collection and the need for equity and the need for equity deserving groups to be a part of that conversation and how that data is collected and analyzed. But where's the accountability part of that conversation? Because we know things are happening, as has been mentioned on the panel here, but then how do we hold these systems to account when we have concrete evidence that certain groups of individuals are experiencing higher rates of mortality when they're going into child delivery, right? How do we know, So I just wonder about the accountability part of the conversation. Thanks.
Myrna can speak to some of the community-based participatory research we're involved in and speak about some of the evidence that's gathered from the research and a little bit more about what her role entails in some of our research projects, or maybe discuss an upcoming research project that we have in store.
Well, one of the ones that we do have coming up is actually, it's the first time that it has ever happened. is that we are going to gather research or data across Canada, so it's Nova Scotia, Montreal, and Vancouver. So it's a project where there are a number of people that have already signed on to be part of this project. We will meet very frequently. We will also travel to place to be able to reinforce what we are learning one from the other. The accountability will definitely be there because that's a missing link in most times when data is collected. And well, we realize that any marginalized group realizes that. I'm not saying other groups aren't missing it as well, but certainly marginalized groups do. And that's why there's such a mistrust within the health system. I'm losing my voice for some odd reason today. Huh? And there's a doctor sitting here.
I don't know anything about throats.
But now you can't say that you can't look after me.
That's true. That's true.
I'm a senior.
The last 5 minutes is a case study.
But it is
just add, sorry, go ahead.
No, but I was just going to say it is quite excellent when we think about different research models, right? So community-based participatory research has been around for a long time. But what we're seeing since the pandemic, particularly in reference to the Tri-Council agency funding, is that there's more emphasis for community members and community practitioners to be directly involved in community-based research practices. So this is the whole part about evidence-based medicine, about thinking about how do we better equip and inform communities that were involved in necessary research, and where does that research take us? That's where the advocacy steps come in. So a lot of the research that we generate, it actually informs finding. We take those research findings, we meet with MPPs, we meet with politicians. Some of us turn into critical scholars, perhaps. But the point is that it's not an extractive process, right? Because we've heard time and time again from communities across Canada, racialized communities, traditionally underrepresented communities, that they are tired of hearing researchers come in, flying in the seat of their pants, extract information, and not follow up with them. And it be merely the result be merely a peer-reviewed publication. That is not conducive, and it is not helpful for communities, and that's one of the barriers that we are looking to break away from, to inform real systems change. That's important.
Can I just jump in for 30 seconds on this? So I'm really glad this has come up, because one of the things that I think is a core competency of a clinical leader is learning how to take data, as imperfect and as different as it may be, to tell a compelling narrative to the decision makers. That's the key piece that's been missing. And that's one of the things I learned during my time with the Canadian Academy of Health Sciences, which are all the top health scientists in Canada. Brilliant people, but not enough of them have the ability to say, okay, how can I tell a compelling story in a simple way that persuades decision makers that this is going to rise to the top of my priorities, because they have many other priorities that are competing for that space. So I think it's a job of clinical leadership to learn the skills to tell the stories that come from the data to the decision makers, and that's where I think we can get a lot of bang for the buck in terms of impact.
Sorry, I'll just add one other thing, which is that I think data are necessary but not sufficient. So I don't think the lens of the camera is worth pointing on data collection when we think about accountability. So should we collect data to inform our system, and can that lead to change? Absolutely. Does it mean that it will lead to change? Not necessarily, as we all know. Does that mean that the problem is the data collection? I don't think so. And you can sort of see from the US, where race data collection is very extensive. That has been able to tell a very comprehensive story about what the sources of racial inequality are. The scholarship on racial inequality in the US is very extensive. Does that mean it's done a lot of real-time good? No, but I find it hard to argue that then means that the data shouldn't have been collected and we shouldn't have had these insights. I made this point, I think, during the pandemic, which is that in my mind, we need the data to have a public record and insights into what's happening in our society. Full stop. Full stop. Hopefully that also leads to change, but I find it hard to marry the data argument with a litmus test that says, well, then you didn't change anything. I think that matters, but it's a different story than whether or not we should have data, which I think on the face of it, we should have data just to tell us whether things have changed or not, to tell us who's suffering and who's not, even when that won't necessarily lead to change, as we see, very clearly down south. One other point, I think you're absolutely right about the unevenness of data collection. When I was working with the Ontario Health folks, that was a big issue, as was missing data. We're just not acculturated to answer questions about our social selves, and I think to Myrna's point earlier, that's for very good reasons. But nonetheless, I see lots and lots of times where there are data collection efforts, but the amount of data you actually get back is low and unfortunately systematically different than the data you would otherwise get if it was complete.
Okay, thank you all. I'm afraid that's time, but good news for the folks in this room. We do have the policy co-design session for all three of our topic areas, but healthcare gets to stay in here. So if you have additional questions for the panelists, please bother them after the applause and as we transition. Thank you so much for being here and for engaging in such a thoughtful way in this dialogue.
Thank you.